Hi, friends. Welcome to another special episode of our YouTube channel, Words of Wisdom with Sanju and Manju. And as usual, Manju is behind the camera. And today we are having a very special episode. It's dentistry across borders, from BDS to DDS. And to talk about it all, we have an international guest. This is the first time we are having an international guest with us. We have Dr. Kavitha Kulkarni from all the way from United States of America. Yeah, Dr. Kavitha, we've been classmates in dental school. So, what's your journey been from there to what you're doing now?
From dentistry point of view, I'm married and my name would be Kavitha Kulkarni right now. I did my BDS at A.B. Shetty Dental College. After that, I moved to the US after getting married. And in order to pursue my dentistry, I joined New York University College of Dentistry at an advanced standing program. That was a 3-year course, and I graduated with a degree of DDS. I was happy to get the Irwin Thal Raymond Award there as the most promising clinical student for my batch. With that, I moved back to Phoenix, which is where my family was, and I worked in corporate dentistry for about 5 years up until I became a mom, and then I realized my time should be better in my hands, and then I opened up my own practice. I have named it as Smilist, as anything else like a stylist or something. We feel we are somebody who delivers smile. And Smilist has been my practice in 2 locations for about 15, 20 years. And recently I sold 1 location and now I'm working out of 1. So I'm an independent private practitioner, a general practitioner, just trying to do my best and maintaining my work-life balance.
Were you always inclined to get into the USA?
Interesting. Well, to begin with, for Words of Wisdom, Sanju and Manju, congratulations on this initiative. Hope this reaches a lot of people and they can pick up a point or two from all that you guys are doing. Now, to answer your question, Sanju, it was not something that I had already planned for. But as you know, back in the days when we were doing our BDS and everything else, everybody was joining MDS. And I kind of knew that my parents would not be encouraging me for doing MDS yet again. And I just wanted to explore something different than what most people were doing, because I felt like once we are in PUC, everybody wants to join a professional college and that gets done. Then it's an MDS, so that sort of what you call as a race never ends. So I thought I wanted to do something different. So yes, when I was in A.B. Shetty, I was inclined to applying for some exploring more than anything else to see what dentistry other than in India had scope for. And marriage incidentally took me there, and I was very clear that I wanted to pursue my dentistry and continue to be a career-minded woman, and had a family and a husband who supported that, and hence continued my journey there.
Oh, that's nice. And you worked in Bangalore for some time before all this happened?
Correct. So after our internship, as you guys all know, with BDS, I was working for NMKRV Dental College as a tutor there for some time. And then is when I went to the US because I got married by that time.
So which year was this when you joined a dental school in USA?
Well, USA, I am batch of 2000. But out there, it is the graduating batch that they call it. So 3 years minus that. So it's like 97 when I joined there.
So how competitive was it to get into university and things like that?
Yeah, it was. So the first of all, when we got married and when there were two kinds of hurdles to cross. One is, of course, the visa hurdles, because you had to become a student visa and had gotten on a dependent visa and all of that. So apart from that, in order to get into college, there were a series of steps that one had to take. In my case, I had to do a national board exam, which is kind of like an entrance exam. And mind you, I did not want to go in as a regular student. So I wanted to go in as what they call as an international advanced standing student, because I was already a dentist here and they were to kind of take us into their curriculum. So I was applying for colleges which offered that. So the number of colleges which offered that and the number of seats were very, very slim. And when I say slim, I mean like about 10 seats or 15 seats. So now you're competing with so many people from all over the world to get into those things. So to apply, even the basic thing was we had to give what we call as national board exams, which were basic, human pathology, anatomy, and all of those. And then there's a part 1 and part 2, basically preclinical and clinical. There was a minimum score that one had to get in order to apply to these universities. And once you apply there, they had their own entrance exams, which was quite tough because it was a lot of dexterity skill exams. It was not all just, vocab or anything like you had to write down. And I found myself competing with the best of the best dexterity skill people from like Japan and things like that. And the tests that they had given was something that we were not at all exposed to, that they were given like a slab of soap, which was used as wax, and they would give you a 3D image and couple of carvers and they would say recreate it. So I was like, how are we going to do this? Our carving was with a block of wax and we did canines and still got scrutinized for all that. And I thought, oh, this must be just something like casual. By the end of the 2 hours, I saw that these people who were really, really good at dexterity, they came up with beautiful images. Sometimes it was like roses, three-dimensional things. So I knew the competition was very, very difficult. But then when you're applying for something, you always look at what's your edge on the competition. They might have had good dexterity skills, but one of the things that the British did for India is they gave us the language benefit outside the world, but they could not communicate. So in my mind, I thought, well, if you're a dexterity person, you're a lab person. You can do good lab work. But if you have to be a dentist, this will come into play because you got to communicate with the patients. So anyways, that's how we kind of entered that whole, process. And I applied for a lot of colleges. It was very discouraging because you had only like 15 seats and there was lots of people applying for that. But they were nice about it. They would call and tell you what you could improve on and things like that. And I realized that a lot of the procedures they made us do was something what postgraduates do over here. In undergraduate, we were not trained for that. And so I did not know how this is all going to work. I applied for a lot of different colleges and I then got into New York University, which had an advanced standing program, which meant that I rejoined another course and they gave me certain credits for being a dentist here in India.
So you've experienced both sides of the coin, like being a dentist in India and now going there. Mm-hmm. So how difficult was it in terms of, and also whether the change of curriculum that you had in US, how difficult was it to bridge that gap?
Well, it was because, there was this feeling that, hey, I'm a dentist and I know all about the dentistry there. So we kind of had to learn the operational style. I'm not going to say that like the teeth were the same, the subjects were the same, the testing.
The numbering was different.
To begin with, exactly. The numbering was completely different because they use a different system over here. So every time you had to rewire your brain, and testing skills were different. We were used to like taking pages and pages and writing, and there it was all multiple choice questions. And you guys know with multiple choice questions, you get less marks for not knowing something versus you're getting marks for what you know. But other than that, I still remember going for the first few, clinicals, and they put up the x-rays and the doctor would tell me what you see. And I then realized my mind was not trained for preventive diagnosis. See, when we were over here, when somebody came to us, it was always an extreme case of dentistry, whether it was an abscess or pain or anything. I was not trained to see incipient decay on an x-ray and things like that. So from then onwards, it started changing. Until today, I feel that if one needs to practice in the US, it's absolutely necessary to go through a schooling system there and understand how you're going to interact with your patients and learn what's the diagnostic approach into treatment.
So I think it is wise for maybe Indian colleges to also have or implement a program for people who would want to go abroad to have that kind of system
Yes.
in play where they can adapt to these kind of curriculums?
Yes, I think, I mean, after I've come back over here, all of you guys are friends, and I've visited a lot of clinics, and I've kind of tried to see how, I mean, I was here till about 25 or 26 years of age, and I've seen dentistry, and I noticed that the focus on preventive dentistry was not there. So when you think about right now, and it's like one person cares for every aspect of dentistry. But in India, I felt like it got divided. Like you brought in a patient, they came in, first of all, not very many people, I don't know, correct me if I'm wrong, they come for a routine checkup. They come with a problem. So the problem leads to the departments, and then you guys have specialties come to your clinic and you separate it. But out there, the general dentist is like, say, the primary person, the primary care giver. And we have a lot of people who come on recall basis. So from what I understood, Colgate, which was like a company, they did a great job on marketing for dentistry. In order to sell their product, apparently they had this tie with the American Dental Association, and they spent tonloads of money on advertising saying that one needs to go to the dentist every 6 months. So there was no hard and fast rule like that, but they did this campaign and it got drilled into the normal people, the insurance and everything else, that one needs to go for a checkup every 6 months. So all of our patients are geared up like that. Of course, there are a few with financial limitations and all, they don't come. But so when they come every 6 months, it's like when you go to your general physician over here. Your blood workup is checked up and your everything like that. Translate it, overlap it to dentistry. So we just do the recall x-rays, we check their gums, we check their numbers. So it's maintained throughout and throughout. So I think that would be a great thing, that you're taking care of the overall health and not emergency-based dentistry.
Okay, coming back to the education part, how expensive is it today, or what kind of costs are involved compared to 25 years ago and now? It would be a lot of a difference.
Yeah, and so it is. That is one of the biggest limiting factor where a lot of people don't go into that. There are not very many programs which offer scholarships and indications to that extent. Back in the days, it was close to 60 grand, 60 US dollars, 60,000 US dollars for a year of education minus everything else. Now I think it's gone up to at least 100,000 US dollars. That doesn't, so hence not very many people go into it.
This is for the entire program?
No,
or is
per
it
year. Per year.
Yeah.
Per
that
year.
we need to specify to our
Per
viewers.
year. Per year. So I know initially when I had spoken to some of the guests in some schools, I was telling them, ultimately, education is one thing, but it also becomes a purely financial decision. Everybody is looking to get an ROI out of it, return of investment of your time, money. So students out there, I feel, are now under a lot of stress, because by the time they get out of a dental college or school and a degree, single degree, I mean, they are in debt for close to 500,000 US dollars. So then they have to join corporates to work, then repay their debts. And then if they have to go and do their own, then again, it's more debts. And so a lot of people shy away because of that, unless they are extremely passionate about this profession.
So is it easy to get mortgages or kind of loans for the education and things like that?
Sure. Student loans are available, but like any other loan, somebody needs to co-sign it for you. And so if that person is not somebody close to you, they don't want to take that credit.
Close to you as in blood relative or anybody?
No, anybody can sign, I think. But there are private places that give student loans, not the colleges. The colleges are not usually involved. They have private, like pretty much money lenders who will bank on your ROIs or like what you're going to provide, and they'll provide
so
you.
So your guarantor needs to have enough
Correct.
money in the bank.
Correct. So yeah, that's the whole
thing. Can it be sponsored from India if somebody has to go there?
I think so. I mean, I'm very surprised a lot of times that even if it's not dentistry, like my kids who are in college right now, there's a lot of international students, and I'm very surprised of how much of funding these colleges get from international, candidates. And it's a myth that no other place has that kind of money. They're spending ton loads on this education. I think it only hurts them when they are not able to recuperate it back.
So there is always a kind of, I don't know whether you call it misconception or whatever, understanding that dentists everywhere make a lot of money.
Yeah.
That is including in India or more so in the US.
Yeah.
So how easy it is to make money?
Well, there's a couple of myths in our profession, as you know. One is that it's the most feared profession. It's almost like the Hollywood movies like gave a little bit of a a villainous or a sadistic attitude to dentists, where they kind of did all kinds
but
of.
Mr. Bean made it nicer for us.
Yes, yes. It is, I think, one of those things like, people keep telling on a standard statement for dentists. All that I would say is, if that is your goal, is to make a lot of money, there is scope for it. But that doesn't mean that's everybody's goal. And the reason there is scope for that is, from a general dentist standpoint of view, I did not do any post-graduation there. You are allowed to do everything as far as your quality of care meets that of a specialist. Suppose something goes wrong, you are held at the same yardstick like what it would be for a specialist. So, if you have a clinic and you have patients coming and you're going to diagnose full mouth rehabilitation, implants, root canals, whatever, and you're going to keep it in-house, sure, you can make. And yes, they can make a lot of money. But some others, like I can just speak for myself, if I said I'm narrowing it down to this much, because for everything there's a yin and a yang. If you make that much, then you have to have staffing, you have to have paraphernalia, you have to invest in all kinds of instruments and x-rays and all that. But you can practice in any which comfort level that you want, because not everybody can afford it. There are like rural areas, there are regular people. So you want to cater to that group of people, it becomes a different form of profession.
So what's the most commonest treatment practice you perform in your clinic?
For me, for my bread and butter, primarily like a general dentist, it is, like I said, there's a routine set of recall patients. So most dental offices, hygiene, which we call as like just cleanings and everything, takes up a big portion of your revenue. And other than that, I'll do my regular crown and bridges and all kinds of like basic dentistry. When I say basic, we do anything specialized, like for example, root canals right now, and you are, you kind of have an interest in that subject. When you send them to a specialist, those guys have the CBCT, they have, they have the microscope. It's done within an hour. So whereas I probably either have to invest in that or I have to get somebody else to come in. So those kind of things I don't do, or wisdom teeth extraction. Also, like I said, I told you before, there's a lot of medical, legal responsibilities you need to take. It's just not that, hey, I pulled it, I'm sorry, it didn't come out, you send it out. That's all perceived as you're not in a same caliber level. So I think one of my seniors, he had told me, as you practice more, recognizing what you cannot do is equally important. But otherwise, sometimes we all have this God complex, like, I'm just going to do it. And if you're not qualified, and if there's somebody better than that, it's best in your interest and the patient's interest to send it out.
So the referral practice is also
very much strong, very strong. And we always have ties with specialties and they kind of go to them.
So the moment you passed out from New York, did you join a practice?
So the thing with out there, what I can say about the educational system is, just as a pure comparison, I don't know if it's a largely right statement, but a lot of times in India, kids kind of come in because of parental pressure or like kind of like a little bit of a society kind of a tag that they want a doctor. We know a lot of people who have spent all that time, energy, money, and today they're nowhere near dentistry. And then you're like, hey, why did you take away someone who might have been interested? So out there, what I noticed is the ones who really want to do it are really, really passionate, because now they've put their money where it is important, right? So after you graduate, you have to take a board exam. So the board exam is divided into different regions of the US. There could be a Northwestern, the Western board, the Southern board, based on our states. And these board exams are going to test you like a practical exam on live patients. So we have to take patients. There's some requirements, like you have to do inlays or you have to do like class 2s. So you go for a testing center and you are to be evaluated at every step of the procedure. So after you prep, after you put the cord, after you take the impression, everything else you are tested for that. That's when you get a license to practice. With that license, you can apply for jobs. So not just getting a degree is enough.
So applying for jobs means you are an associate with somebody.
Different ways are there. So yes, you could become an associate, which is how I started in the beginning. Or if you want to go ahead and start your own, you can. But just like us, most people, when they just do 5 years, they're not confident to do that. So they will either join as a mentorship with somebody, like an associate with somebody, or they will go right now. The corporate dentistry is increasing. For some reason, it is a country where money speaks more than anything else. So a lot of people invest in dentistry as if it's a business. And then they will hire dentists to work for them, and they come up with the lucrative financial arrangement. For so a lot of dentists for whom running a clinic, which, as you guys know, which I would think no matter which part of the world we are, I think the curriculum should include taxes, financial, like MBA kind of a thing for basic dentistry, because we then realize we're not just in healthcare business, we are also in trying to run a business. How do you how do you talk to your employees? What do you kind of offer them if you're having a larger practice? So for a lot of dentists, they find this doing your own practice a very challenging thing. So they'd rather go to a corporate where that's taken care of. They're also an employee at a different incentive.
Yeah, and the marketing is also done by the...
Yes, so there is a lot of, it's like a big business. There's marketing, there is people personnel, and there is patient care, follow-ups, and all of that.
So that's good. And now with the things about digital and digitization and CAD CAM and things like that, how has that caught up? It's like a norm.
It's a norm. It's a norm. We all went digital. We all, checked our X-rays and all a long time ago. CBCT has become so common right now, wherein now we realize that it's so much more diagnostic than just an X-ray. So it is kind of becoming the norm that way. And we are all transferring our records. In fact, like when I come here for medical treatment for my family or anything, I just noticed that records are transferred just in WhatsApp, and it's not there. It has to be done in a proper fashion. But I am not too sure if I say that that's efficient or not. I find the way they do it in India more efficient. You feel like you're crossing unnecessary hoops. But also here, our population is so much that if you keep following those rules, things will never get done. But out there, I think patient privacy is so important. So you cannot even send your X-rays in just a regular email. You have to go through like a portal system, which is kind of locked, so the other people have a particular password to open it. In dentistry, not that big of a deal, I think. But imagine if it was your medical history. It's your private personal history, and there is a huge doctor-patient privacy, including like when we have patients come in, we cannot discuss the wife's case to the husband unless we have his consent. We cannot discuss the 18-year-old case with the parent unless we have consent. So sometimes even simple things like if we want to ask the 18-year-old his medical history, and I want to ask him, are you using any recreational drugs? He will not choose to answer it in front of his parents. That's their right. So that's why it becomes all digitalized.
And also, I think because of the kind of litigation cases.
Yeah, big time, yeah.
So is there something, of course, definitely you'll have that indemnity insurance.
Oh, yes.
Like that.
Yes.
So does that play a big part in your financial implications also?
Yes, we always have to have insurance. We get ourselves covered for that because, the litigation was put in place to protect both parties, just like a contract. When we sign up a contract, it's a legal document, like, Manju should know more about it. It protects both parties. So when we do not do that, what happens is that some people take undue advantage of it. They just have this thing, like you said, oh, I can tap into this and I can make some money. And so there's ton loads of sometimes it just does not make sense. I don't know if you have the time, I can quickly narrate to you like how it kind of comes about. This was presented to us in one of our courses. So I have an employee. She's not clocked out on my lunch hour. She goes outside to get food. She meets with an accident. Unfortunately, the opposite person has a fatality. Now they will look at who the person is who did the accident to see if they can sue or whatever it is. They realize this person cannot afford that. But their lawyer was sharp enough to find out that she worked for a dentist. They traced that loophole to find out that she was an employee at that time because she had not clocked out. They came back to sue the dentist and wiped him clean.
Oh, wow.
And so he ended up paying for something. So things like this. So your mind always goes in like defensive mode. You're always protecting that. So yes, we all have to carry insurance at all times. If we leave jobs, we take what we call as tail insurance because it has to carry for about 7 years after our work. So we save our records for 7 years. Anybody can come within the 7 years and ask us for all of our records. So we have to save it.
So you've been running actually two
Correct.
practices in Phoenix.
Correct,
Right?
yes.
You didn't mention that.
Yes.
She's in Phoenix, Arizona.
Yes, yes.
So how many staff do you have, and maybe a kind of a small rundown on your clinic? And
Right. So, I kind of started two practices mainly because I wanted a cross section of population which was different. I started it as when my kids were little, and like I told you, I am not one of your completely a huge corporate kind of a setting. But starting my own practice just helped me balance my work-life balance, and I believed in that. I wanted to not let go of my role as a mother or a wife, and I wanted to be alive and not make just dentistry my own profession. So I started these two practices. And yes, you have staffing in terms of the front office, minimum staffing, even as a front office, a couple of assistants, a hygienist, and things like that. And it went through different, ups and downs based on how much time I was giving to it as well.
so were you closing this practice when you were going there and the same staff going there? Or
Yes, so I kind of did something which was, again, I think it's complex for a lot of people. I did like a reverse rolling. In other words, like every office, I would, if a patient wanted a Monday, I was available a Monday in that office, but not consecutive Mondays. So I would just rotate my staff. So the whole group of us would go Monday, Tuesday, Wednesday, office A, next Thursday, Friday, whatever, office B, and the next week I would flip it. Each offices had a mirror of the computers of the other office. So when a phone rang, we would ask which office they are a patient of, so we could book their appointments and continue with that. But that's the way I did it.
So the rest of the time, the other office would be closed.
Kind of, yes.
So now there is a kind of a flurry of patients who are booking online appointments by
Yes.
themselves.
Yes.
So does it help in any way in the practice? And what about the other practice which you had? You said you closed down.
Right. A lot of them do online, but out in the US, one of the things that I like because it suits my personality is it's a very time conscious place. So when somebody tells you that you give them an appointment at 8 o'clock, they are there at 8 o'clock, you are ready by 7:50 with everything that they need. If they do not come, you give them a grace period of 10 minutes. After that, you do not see them that day because you have somebody else at that time. And then you charge them a late show fee. So you can, in your own clinic, kind of say that, hey, I'll be human about it. I'll give you like 2 times. But sometimes people will be taking you for granted. They keep making these big, long appointments. They don't show up. Then we're struggling to fill that gap. So it's like you train your patients to the culture of your office. You don't have to be mean about it. You just have to say sorry. But you got to keep up your end too. You cannot be late as well in procedures, so you got to time it. So online, what happens is, if they are not somebody whom we know, then that relationship is not there. So I prefer them to call the office.
So just off the record, and for others, what's the late fee?
For not showing up. Well, in my office,
so that we can do it too.
Yes, no, it's like how if they want your services, they've got to abide by your rules. It's how you set up a culture. It's just like our families and everything else. What do you tell our kids? Like, this is the norm of this family. My kids have a curfew time. They cannot come later than that. It's a set rule, and the kids all abide by that. So the same thing is that the patients have like 10 minutes grace period. If they don't show up, I'm pretty lenient actually. There is a $25 late charge fees.
So that is taken off from the insurance?
No, it's from their pocket. Insurance is not going to pay. They will pay. Sometimes some of them are very nice about it. They understand that they are paying for your time. At times I'll have a senior person who calls me and says, "Doc, I'm not feeling too well, but you've booked for me, so please charge me." They themselves will tell. But some others, they don't. So you kind of go with the flow on that.
So, is there a set system of, say, treatment fees, or are you having the freedom to charge your own fees?
Interesting question. We call that usual and customary fees, UCR, kind of a regulated fees, and which is again a complex thing in the US. You can set up your own fees. You can be insurance free. So let's kind of take, for example, what you like root canals, he likes extractions, so whatever it is. Extractions is another story there because everything is done under sedation. So even if it's a simple extraction, it's done under sedation. So sometimes I feel people go for extraction because they cannot afford root canal and a crown, but end up coming back much more expensive because they ended up paying for sedation and all of that. But let's say a root canal, for example, an anterior root canal, on an average, it will be like $1,500 UCR fees. That is, you can charge up to that for you to, otherwise there's lots other people who'll do it. But if you are like signed up for their insurances, let's say Delta, which is one of the bigger insurances, you as a Delta provider have a contract with Delta saying that if a patient comes with your insurance, I'm going to bill you $1,500, my UCR. You will adjust it for me. So I adjust
Something
it
like
up.
a copay.
No, they'll adjust it. The insurance itself will adjust it. So the Delta patients are adjusted to, let's say, $1,000. And based on their insurance, it's 50-50. So the patient pays me 50%, the insurance pays me 50%, and I have write-off, what we call it, another percentage of it. So you kind of have a little complex mathematical thing if you accept a lot of insurances.
So we know that sterilization protocols and things are very
Yes.
much, at work there.
Yes,
And
yes,
is
yes.
there a regulating authority for that? Do you have regular inspections and things like that which happens?
There
or
are-
surprise inspections?
There are supposed to be that, but knock on wood, in this 30 years of career right now, I actually 25 as a practicing dentist, the other one I was studying, I've not had anybody come and inspect, but there's a lot of cases wherein, I'll tell you what, during COVID times, we were all so scared, and I wrote an article over there. I'm like, I think dentistry is doomed. Where are we going to maintain that 6 feet kind of a thing? But I think it's such a proud thing for all of us dentists. Even in the US, there was not one transmission related to the dental field because we were used to sterilizing operating room, because anytime a patient comes and goes, there is automatic like wiping down, wrapping up and all of that, so that intertransmission is not there. But out there, we have to be very, very cautious. Like, all instruments are opened in front of the patient. We are gloved up like we're doing like major surgery, not like touching the lights or anything like that. If something falls down, we will tell the patient, I'm taking out the gloves, I'm putting my new ones, so they're not kind of feeling that. And every patient has the right to walk into your sterilization area and kind of see it, whatever it is. Where the regulatory board will come is, let's assume a dental office ends up with kids, they see kids, and all the kids are falling sick, and there's a pattern that they went to the dentist, then the investigations start. So our water lines, everything. So there's a protocol for just keeping the place active. So not only our sterilization thing, our water lines are all maintained a way that we have to, abide by. The answer to your question is they can come, but they don't do it that often. That much is not theirs.
So you mentioned about extractions under sedation, conscious sedation for that matter, and you're doing all the extractions under sedation?
They don't want pain. They don't want to feel a thing. And I think oral surgeons just find it easier to just like give them something and do it. Though sometimes I find that because I worked over here and I'm like, it's a mobile teeth. But and then they praise the doctor saying that I did not feel a thing. So that I did not feel a thing is worth the money for everybody.
So does it make it mandatory for anesthetist or somebody who's trained in resuscitation and things like that to be present during that time?
Yes, a lot of the ones who do extensive surgeries, they have anesthesiologists who come to their office. They kind of put their procedures in such a way that they have proper anesthesiologists. Some oral surgeons take it upon themselves because they are doing like 15-minute suggestions or something like that.
Okay, now coming to another part of the thing, what kind of visas are, like somebody wants to go from India to the US and maybe get into a dental school, what kind of visa would be needed?
Student.
Student visa.
Student. The only problem is after student, then what? Then it's work visa.
So if it is after marriage, is it a dependent visa?
Yes, I went under dependent visa, converted into US visa. Back in the days, there was a process, and then I got my green card and my citizenship. So I don't think I'm in position to say what the current situation is. And I just know from not a dental background, which I feel bad for a lot of people who've come looking for a better life out there. America was a land of immigrants, and now the weather and culture is changing.
So do you think the present regime is making it more difficult for people to come over?
Most certainly, because the locals kind of felt that their jobs were taken away. So it kind of started out like that, but it's a very conflicting, and I don't want to go to the political part of it, but it's a very conflicting basis of America. Any other country we could understand, but as you guys all know, America is a land of immigrants and equal opportunity. So the fact that, but from the flip side of it, though I have a preference in my political thing, but on a flip side of it, they felt that there were a lot of illegal people coming. And we are all under the thing that illegal is not to be encouraged. And I think whether it be India or America, that's true. But now the imposition of that has no rhyme or reason there.
Okay. So now, how different are US patients compared to India?
Very interesting question. Very interesting question.
Whether it is
I love it.
expectation-wise or anything else.
In India, patients are very, at least the ones that I kind of knew for, I think they look at doctors very, very, like there's a God complex to it. They are like, whatever the doctor says. Out there, they are very educated that way. They kind of know, so they are expecting a service. They're not very pain tolerant, even a little bit. And I think that's why sometimes we steer away. I started off doing a lot of, extractions and everything. And then I would have a 7-foot African-American guy with like extremely strong jawbones come in. And then he's acting like a baby the minute I'm trying to extract. And I'm like, I think you should go for sedation. Then I don't look competent enough for that, They don't have pain tolerance that much. What's good about it is they will pay for your services, which is a flip in India. They always are expecting discounts and a cheap service. They will pay for your money. And if you're good, they'll pay anything for it. They have time sense. They're not going to screw up with their time and not our time. They are interested in maintaining their teeth. The biggest thing is when you come over here, they'll be like, I've got married right now. I don't need to look fair. Doesn't matter. I don't care about my teeth or whatever it is. Out there, a 95-year-old person is, as long as they are within their senses, they have complete smile line, affordable. I'm not generalizing. Of course, there are some people who cannot afford, but they like teeth is, they want to keep that as long as possible. Aesthetically, they are very conscious. Then there are people who are cosmetically very, very oriented. All the time they want veneers. And so if you are into cosmetic dentistry, then that's kind of a thing. So that's probably some of the primary ones.
Okay, but since you have mentioned cosmetics into it, are there dentists practicing with the Botox and other skin?
Oh, yes.
Is it catching up there?
Very much so, very much so. All our CE courses, because who better to give a shot than a dentist? There's one thing that we do.
Is it legally allowed?
It's legal.
For any DDS graduate?
You have to go training. You need to know where you're going to give. And Botox and cosmetic among the women is a very, very accepted culture. Just like how you would, say, go for an eyebrow threading there. You'll go for your Botox replacement every 2 to 3 months. You might look like a duck at the end of it, but they think that is more.
Ducks are beautiful.
Ducks are beautiful, sure. No, but it's all in the perception. They find that they don't want wrinkles, so they all go, and it's not a taboo. It's not like oh she went Botox. It's normal. It's just normal.
Okay, so now coming to the end somewhere of the podcast, how is your work-life balance, and what's your day like? Typical day.
Typical day like. Sanjay, I think if there's one thing I do take pride on is I do maintain a good work-life balance. I think just this morning, one of our friends were asking me, how is it that you do all of this? I just think compartmentalizing your life and being present for that compartment, you just have to decide what it is. So I am a mother of two sons. I am present in their life. I will attend all their matches. For my day starts in the morning. We are not into a heavy breakfast kind of a culture. I also adapted to
You
that.
didn't specify the time.
In the morning, how early? I'll wake up at 6:30. So I wake up at 6:30, and then we are all done with our breakfast. By 8 o'clock, I leave my house. All of the family members leave. I'm at my office. I'm there I'm just kind of talking for myself. Other people might do it different. I'm there by 8:30. I start giving appointments because I work in a retired community. I chose later on to work in a retired community. I just like that old age culture than the fast-paced culture of this generation. So then by 9, my appointments are booked up for the day. I am there till about 3:30, 4, and I'm done. At that time, I come home in time to be for my kids, whether I'm taking them to their soccer or fix their dinner, meal, cook, whatever it is. I go to my little exercises. I have a fur baby, so she makes sure that I do my walkings and everything like that. Spend time with my husband, and then we don't work on weekends there, so which is a good thing. And I see a lot of people, my friends, they're just like all working over the weekend. So that's my Monday. I do take Wednesday as a midweek admin day. I do not work on Wednesdays either, because I use that time. You asked for work balance. I use that time to go do my extra gymming or whatever that I want to do, or for my own personal doctor's appointments or shoppings or something that I don't have to do. And or I go to my office and do paperwork and buy supplies or whatever else that I have to do. Wednesday is a midweek break for me. Then again, it's Thursday, Friday. A lot of people take Fridays off, but then Saturday, Sunday, we don't work. So when you tell that dentists make money, so when you look at it, I feel like I work 4 days, and I think I'm okay with what I make with that. It's what I make for how much I put in.
So now we have finished about 30 years of practice. So how is the networking and the mentorship going on? What next?
See, that is a challenge for a lot of retiring dentists, because as you guys know, eyesight fails. I mean, after having used loupes for 30 years, I just feel like you gave a price for it with your back pain and neck pain. So therapies like massages and all have become like a course of my own life, because I cannot work otherwise. A lot of dentists do join colleges for mentorship. I had tried in the beginning because that was the culture in India, that we join colleges. But then I realized the people who teach there are of extremely high caliber. Like they are like PhDs and things like that, that I was like, I don't know what I'm going to do in front of them. And the way they taught there was, it was not your disciplinary. It was like, it's a canine teeth. You need to know everything that needs to happen with the canine. And I'm like, I'm sorry, I'm not the right person. I'm not qualified for that. So a lot of them do these kind of, volunteering work in the clinic, or there are like volunteering clinics that they can go. Doctors Without Borders, they go to like Mexico and other countries, they can kind of do that. But some of them who are still able to do, there's no time limit. You have 70, 75-year-old endodontists who love what they do. They'll continue to do it.
So in the same breath, how is burnout in dentistry in the US?
It is because it gets taxing. It gets taxing because you're so, it depends on your team. If you have a team that stays with you forever, then you have all understood each other. Otherwise, the current generation, they are not interested in the same work ethic. They don't show up on time, and you are now liable. So all of that becomes very taxing. And so then you keep working lesser and lesser. So yes, it kind of will affect you. But retirement, post-dentistry, there are not too many options unless you join some insurances and become their advisory dentist or something.
So
like
what
that.
happens to the clinic that point of time?
You sell it. You sell it to somebody else, a new dentist who will pay you value for your patients. They'll look at your revenue. Typically, it is evaluated at 70%. They'll take 3 years of what you made and they'll pay you for the patients as well, goodwill, and your thing. Now, you don't want to do it, which I sold my earlier one that way, but if you don't want to do it, you can taper down, stop taking insurances. You can make your practice only cash-based, so then your volume decreases instead of increasing it. But people they will always evaluate you just like any acquisition and merger of any business. It is a business at the end of it. And so then you can sign up saying that I'll work for your company for another year or so. I don't want this other responsibilities, and you taper out.
So friends, I think it is so much of knowledge that people who would want to move to US or apply in universities in the US would have got from this great.
Not great and all. You guys are just friends.
Great
and
classmate
so
of ours.
I'm just here kind of telling my only two things for anybody who wanted, if not US, who wanted to elevate their own practices over here is give importance to record keeping and create an environment where you create the culture for the practice. Sometimes there they have like spa and all other foo-fa things, but whatever it is, that's service-minded, like the service-minded, which is what America is known for. Like all of you guys know that you go somewhere and you don't like it, they are just going to refund and do it. Some people misutilize that, but if that service is available with respect to their time and our time and preventive dentistry, you're leaving a lot of things on the table. So when a patient comes in, full mouth x-ray is mandatory, and I keep telling everybody, you do full mouth x-ray, you will diagnose something that can be prevented from going into a root canal. Whether you can convince the population or not, that's for the larger marketing people to advise that.
So thank you, Kavitha,
thank
for
you.
Sharing every aspect of.
Sorry, it was a little fast, but I kind of tried to put that
crossing
through.
borders, it was really kind of a great knowledge that you have shared.
Thank you.
Thank you so much for being a part of our podcast, Words of Wisdom with Sanju, Manju, and Dr. Kavitha.
Congratulations and best of luck for the two of you. We as a group have worked on multiple projects, so I didn't see after this many years we would be doing something like this. So this is a treasured moment for me as well, but all the best, and hopefully your viewers will get a point or two. Thank you.
Thank you. Thank you.